Hi, everyone. Welcome. Thanks so much for coming into our room for our UMiami Health Talk tonight, our virtual talk called Transform Your Life with Bariatric Surgery. I'm health journalist Ileana Bravo, and I'm going to be your moderator for this evening's UMiami Health Talk, and it's presented by UHealth Bariatrics Specialists. UHealth Bariatrics Specialist is a regional leader in bariatric surgery, accredited by the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program. And it's a comprehensive center with adolescent qualifications as well. They're a highly trained and experienced team with leading outcomes in bariatric surgery. Their internationally renowned program features the latest treatments with mind and body-focused care before, during, and after surgery. We invite you to learn a lot more about UHealth Bariatric Specialists by visiting uhealthbariatrics.com to make an appointment, and you can also call 305-689-1910. So let's get on with our program. Tonight, we're going to hear from the Chief of Bariatric Surgery at the University of Miami Health System, Dr. Nestor De La Cruz-Muñoz, who will talk about the health effects of obesity complications and how surgery can make them better when bariatric surgery can help improve your health, review of the surgical options available, and the pros and cons of each one. And finally, he's going to discuss UHealth's bariatric program and their commitment to helping you achieve best results. Now, at the end of this presentation tonight, there's going to be a question and answer session, and Dr. De La Cruz-Muñoz will field your questions. It's a very special time for you to be able to present those questions to him, and you can enter them into the anonymous Q&A feature at the bottom of your Zoom screen. Whatever device you're on, take a moment to locate that. And as you think of the questions, we're going to prepare them for our expert to address at the end of his presentation. So as you're all continuing to gather for our webinar tonight, now let me take the time to introduce Dr. Nestor De La Cruz-Muñoz. He's a professor of surgery, a fellow of the American College of Surgeons and the American Society for Metabolic Bariatric Surgery, and a diplomat of the American Board of Surgery. He has performed over 8,000 bariatric surgeries using minimally invasive techniques. He was on the forefront of adopting a minimally invasive laparoscopic approach for bariatric surgery. He has presented nationally and internationally on bariatric and general surgery topics, and as a national leader for outstanding surgical outcomes, he's received numerous awards throughout his career. So please join me in welcoming Dr. De La Cruz-Muñoz. Take it away, Doc.
Well, thank you very much, Ileana. Let me share my screen so we can get started. Okay. So we'll start with what morbid obesity is, and we use something called the body mass index, which is a measurement of height and weight. You can calculate it by searching BMI calculator online, and you input both your height and your weight, and it gives you an idea. Ideal BMIs are between 18 and 25. Over 25 is considered overweight, over 30 is considered obese, and over 40 is considered morbidly obese. And that ends up being about 100 pounds over an ideal body weight. In the US right now, 75% of us adults are overweight, and 1/3 of adults are obese, and nearly 10% of adults have morbid obesity. So it's an incredible amount of us are suffering from this disease already, and that means there are over 26 million Americans that have a BMI greater than 35. So this is something that is not rare, but it happens all the time. Why is it important? And it's important because obesity and its complications are the second most common cause of death or preventable death in the United States. The estimates are that 300,000 Americans die a year because of obesity and its complications. And even though you'll hear opposite in the social media and out all over the place, morbid obesity is a disease. And some of the main causes are genetics, and it's in our genes' interactions with the environment, and how they respond to the environment. And so it's a lot more than just a willpower issue or a personality flaw or an eating disorder. There's a lot more going on that is a little bit out of people's control, out of people's control. We know of 256 medical problems that are seen with obesity. it's incredible. It affects every single organ system in the body. And some of the big ones are high blood pressure, heart dysfunction, where the heart muscle gets thicker and doesn't work as well, lung dysfunction, where sleep apnea is the most common thing. Diabetes is incredibly common in patients that suffer with obesity, arthritis, heartburn, urinary incontinence. I mean, the list really goes on and on. Some of the interesting things down here at the bottom, risks of cancer. We know of 13 different types of cancers that are hormonally based that are more common or worse prognoses in obese patients. And fatty liver occurs in 70% of obese patients. Fatty liver and its consequences have overtaken hepatitis as the leading cause of liver transplantation in the United States. So it's affecting all aspects of medicine and all aspects of health. You know, question is why surgery? Why the heck, why would we submit ourselves to getting cut, you know, changing our anatomy? You know, didn't God make us the way he wanted us to be? And why not just use diet and exercise plans or medicines? You know, there are some new medicines that are coming out now, and we'll talk about that a little bit. You know, they're safer to use. Well, the answer is supposedly they are. And the problem is that although diet and exercise plans can work, for the great majority of people, they don't tend to work long-term. And obesity is a chronic, lifelong disease that if you don't fix it for the rest of your life, the process will continue and keep getting worse. So short-term plans haven't been working for most patients. And then if we look here, this is an old study looking at surgery versus medicine. This arm, the patients had their BMIs were high, they were 47, and they underwent surgery. And at 6 years, their BMIs were down below 35. When they underwent surgery. But the group here that underwent medical treatment had started with a BMI just above 40. They dropped down when they dieted. They did well, but then over the next few years, they regained the weight back and they were back to where they started. So it really wasn't working long term. And then if there was a study looking at the British electronic medical records, and they found that the yearly likelihood of decreasing a body weight to normal was 1 in 210 people for men and 1 in 124 people for women. And if you are already at a BMI of 40 to 45, that number went down to 1 in 1,290 for men and 1 in 677 for women. So people whose BMIs were already in the 40s, the chances of them ever getting down to a normal BMI without surgery, just by diet plan alone, is incredibly low. So are they really safer? Not really, because we have to look at what the health risk of being obese is, and we'll talk about that. In opposite surgery weight loss outcomes, this is just a standard surgical post curve, and you see excess weight loss percentage. And these are patients that did really well, good weight loss responders, and they lost about 80% of their extra weight. And the ones that did poorly lost about 30 to 40% of their extra weight. So this is, again, a huge difference compared to what we saw in the other curves, where the patients by 2 years had already come back down to about where they started and would be down in here. So this really was one of the studies showing longevity of weight loss outcomes in bariatric surgery. I want to show you some of our data, because you can talk in general about what's going on, but we just published our data on patients who were young, 21-year-olds and younger, an average of 14.3 years out after surgery. The patients after that much time had still a total body weight loss of 31%, meaning they had still lost 1/3 of their total weight and maintained that weight loss off for an average of 14.5 years. So if they all started at an average of 300 pounds, when we followed up with them, they were weighing an average of 200 pounds. So actually the actual numbers are, they were weighing an average of 278 pounds at surgery. They were weighing an average of 195 pounds when we caught up with them 15 years later. So the weight loss outcomes were incredible. And these were a lot of patients that were lost to follow-up for years and just seeing their primary doctors and their other physicians. So this is real life data, real life numbers showing longevity of outcomes. So we know that surgery cures diseases, and it decreases, and the incredible part is it also decreases the deaths from future medical events, which is the really cool stuff. The data has been out there for over a decade that surgery can cause a resolution of current comorbid conditions, meaning it can cure the diseases that patients have now. And that comes from different types of studies, everything from case series to randomized trials. And it's clear that this really makes a big difference. The cool stuff that's been coming out in the last few years is the prevention of future metabolic events. So we know we can get rid of a lot of the medical problems, but is it really making a difference in terms of longevity and health in the long term? And now there's a couple of great studies that have come out in the last year, one out of Utah and one out of Sweden, that looks at huge thousands of patients, population studies of patients, and they showed a decrease in the diagnosis of new comorbid conditions. So there were less diagnoses of diabetes, high blood pressure, and heart disease in patients that had undergone surgery than in patients that were obese but had not undergone surgery over 10, and even in the Utah study, up to 40 years that they followed the patients. There were less cardiovascular events, meaning there were less heart attacks and strokes in the patients that underwent surgery compared to the ones that didn't. And there were less obesity-related cancers, less diagnosis and less mortality in the patients that underwent surgery compared to the ones that didn't. So, and there have been a bunch of studies that have shown decreased long-term mortality in the patients that underwent surgery compared to the ones that didn't. So it's incredible. What this is showing is that we can't ignore that obesity causes disease and it causes early deaths, early heart attacks and early deaths. And so a lot of times people think, well, I'm just overweight, but I'm healthy. And that's not really true. Over time, it tends to catch up on people, and the numbers have been showing it, and especially in large numbers right now with the data that's out there. So the surgical treatment of obesity, the criteria had been the same for 30 years. And last year, the American Society for Metabolic and Bariatric Surgery and the International Federation came out with new criteria. And what the recommendations are for surgery is it's recommended for individuals with a body mass index above 35, regardless of the presence or absence or severity of comorbid conditions. So just having a BMI above 35 is more, and not doing anything about it, is more dangerous than undergoing bariatric surgery to decrease your BMI. And then the second group is the patient metabolic surgery should be considered for individuals with metabolic disease and BMI between 30 and 35. So people that are a little bit thinner, but already have metabolic disease associated with obesity, they have diabetes, they have high blood pressure, they have heart disease, those guys also the benefit leans more towards undergoing surgery than waiting until they get older, sicker, or bigger. And the BMI thresholds are a little bit lower for the Asian population because it's been shown that Asians tend to be affected by weight at even smaller BMIs than Caucasian patients do. So what happens? The long-term studies for people that undergo surgery, I already told you that the data shows that people are alive longer after surgery. The Swedish obesity study is out 20 years. Adam's study in Utah was originally 10 years. Now it's out to 40 years. McGill in Canada had a study out 5 years, and all of them showed a 40 to 89% decrease in the death rate in the group that underwent surgery compared to the group that didn't undergo surgery. So yeah, surgery is scary, but being obese or having obesity should be even more scary, and can't be ignored. And then if we look here, these are 29 studies, all looking at the same thing, and all 29 showed a significant decrease in mortality in the group that underwent surgery. And these are all published. These are not little journals. This is JAMA, New England Journal. This is some of the biggest journals in medicine where these things are getting published. And so this is real data that's important stuff showing significant decrease in mortality. So what do we do before surgery? It's not like you call us, and next week you're getting surgery. We want to make sure you're medically ready and mentally ready for this. So first step is consultation with me to go over your history and find out what's going on, what your medical history is about, what your goals are with surgery, which surgery you're thinking about doing and why, and trying to figure out the best surgery for the individual patient. Then the psychological evaluation, everybody does. The big thing we're looking at is do you have the psychological tools to handle the stress of the switches that we do with food after surgery? Everybody sees the nutritionist before and after surgery for counseling and an evaluation initially, and then counseling after. We do some x-rays, we do some blood work, and then all of you guys are different. So we use other evaluations as needed. Cardiologists when needed, sleep studies when needed, neurologists when needed. So depending on your particular situation, we'll use other professionals to make sure that we can optimize the patient medically before we undergo surgery. And then one of the last things we do is put everybody on a preoperative, very low calorie diet. And what that helps to do is shrink the liver and get the fat out of the liver to make it smaller. And it actually gives us more space to do our work. And by giving us more space, it makes it technically easier and we feel decreases the complication rates of doing the surgery. After surgery, we want to see you guys forever. Okay. And I like when I give these talks live because I can look at all the patients out there in the auditorium and look at their faces and say, if you guys are like my other patients, you're horrible because you just start disappearing. And we want to see you guys forever. And we know that you can do real well if you keep following up with us. So we ask you to please follow up with us, and it's lifelong. We're going to see you in our office. You're going to continue with your medical follow-ups and your normal stuff, and we'll continue offering nutritional counseling forever. We're going to want to put you in an exercise program with several different things that we offer, and a support group. And there was somebody asking, what if I can't do exercise? Everybody can do some kind of exercise, and we work to tailor it to whatever your capabilities are. Whether it's non-weight bearing or weight bearing or whatever the limitations are, there's always something that we can do to help stimulate metabolic activity and help with weight loss. Our office is kind of unique in South Florida in that we are really a focused bariatric office. There aren't many like this, and all of you will have a patient advocate, and this is the person that works with you to help you make your appointments, helps you get the results, works with your insurance to get you authorized, and make sure that everything is all set up so you can work your way through the pathway to surgery. They're your helper to get you there. We don't just give you a list and tell you go start making appointments everywhere. We have right now one, but we always have two full-time nutritionists. So because we take nutrition counseling before and after surgery that seriously, that we want to make sure that you guys have really good access to nutritionists to help get all the information, reinforcement, and knowledge there so you can get the best outcomes available. We have a bariatric coordinator whose job is basically responsible for all patient and staff education. She's the one that maintains our Center of Excellence accreditation, which we just finished undergoing our site visit a few weeks ago, and it looks like we passed again for another 3 years. And she helps set up and run the different classes that we do. And then we have a nurse practitioner who helps me by seeing patients with me initially and seeing some of the follow-up visits. She monitors the lab results and test results. She offers and helps with some medically supervised weight loss. She manages prescriptions. She does follow-up care. So a lot of the stuff that I wouldn't be able to do all of because there's only one of me, she helps being able to do all this stuff. And you guys will all meet her in time if you call our office. So talking about the different surgical procedures, there are different classifications, and I break them down into endoscopic procedures and laparoscopic procedures. And we're not going to talk about the endoscopic procedures today, really because they are not quite ready for prime time. They are not quite permanent. The weight loss is not the same. And I'll be happy to talk to you more about it individually. They're also not covered by insurance at all. But so for most of the patients that are considering bariatric surgery, an endoscopic procedure is probably not the right thing for them. This may be for patients whose BMIs are lower, just on the threshold, and are considering something. But once a BMI gets above 30 with illnesses or above 35, we're really talking about moving towards one of the laparoscopic procedures. And tonight we'll talk about the gastric sleeve, the gastric bypass, and the single anastomosis duodenal switch. So the gastric sleeve is a procedure. We do all of these laparoscopically, which we make different incisions in the abdominal wall. We put in little tubes that we call trocars through the abdominal wall that allow us access inside. We fill it up with gas, and then we have long instruments that allow us to work inside, and we put a camera inside. And then if this is the esophagus and the stomach, when you eat, a normal stomach will eat and fill up, and then it'll drain out of the stomach into the small intestine. But a normal stomach will hold about 1.5 to 2 liters of food and fluid. And so what we're going to do is we're going to trim this stomach when we do a sleeve with a stapler that cuts and staples and remove the outer part of the stomach, leaving the inner side of the stomach here alone as a small tube. And this ends up being about 4 ounces in size. Now, the surgery doesn't just work because it makes the stomach smaller. The gastric emptying is a little bit faster. Small bowel movements are a little bit faster. And some of the hormones that are being produced by the distal small intestines work differently to provide better feelings of satiety or fullness in patients that had a sleeve. And that's more likely how it works. The surgery itself takes me about half an hour to perform. Most of the patients spend 1 night in the hospital. About 15% will spend 2 nights in the hospital. Usually by the time you go home, patients are off medicines, off our, not on any pain meds or anything for nausea. And although I tell you to ask for 2 weeks off of work, most people tell me that within a week they could have returned back to work. So the physical recuperation is actually really quick after these laparoscopic surgeries. And I don't put any of my patients on limitations after surgery. The old limitations after open surgery were that they were scared the incision would break and everything would bust out from inside. But these incisions are so small that the risk of hernia is really small. And so you can go to the gym that week after surgery. You can do some lifting. You can do some exercises. You can do all sorts of, whatever you want. You can do jumping jacks, you can do cardio, you can do Zumba, whatever it is that you want. I've had patients that were judo instructors, and they resumed judo after their surgeries once they felt comfortable with their stomachs. So the lifestyle is relatively normal afterwards. There's no lifestyle limitation after these operations. And then let's go to the next one. I want to show you the anatomy of the bypass. The bypass has been around since 1967. It's been here for 50 some years. And what we're going to do is we're going to use a stapler to make a small stomach pouch. Now, the rest of the stomach is not removed. It's actually left in place. And so the bypass theoretically is reversible. Then we go down below, cut the small intestine, and bring the farther down piece or the distal piece and join it up to the stomach above. And this way the food travels down through the stomach and into this piece of the small intestine. This stomach still produces fluid, so it has to drain. And what we do is we come down here and join these 2 pieces of small intestine together so that the juices from the stomach and from the pancreas can flow and mix here with the food that's flowing down in the blue. Okay, this operation, I've probably done 4,500 of them, maybe closer to 5,000. I do them normally in about 45 to 50 minutes. And I always tell the patients, if I didn't tell you which operation I did, you wouldn't know. The recuperation of the bypass and the sleeve and even the duodenal switch are exactly the same. The patients feel the same pain, the same everything. And so by the next day, most of the patients are ready to go home. There's actually even a little less nausea and vomiting the first day after the bypass than there is after the sleeve. It's probably about 5% with the sleeve the first day, and about 1% the second day. With the bypass, it's probably 1 to 2% the first day and almost 0 the second day. So the recuperation is about the same, but the surgery works mainly by stimulating the small intestines down here and to change the way they produce hormones, and makes people feel full faster. And it also helps with the improvements in diabetes, even stronger than the gastric sleeve. And we'll talk about that a little bit in a second too. Single anastomosis duodenal switch is a newer operation that we've been doing. And what it essentially is taking a gastric sleeve. And so we first form a gastric sleeve, cutting the small intestine after the end of the stomach, and then bringing up a piece of small intestine from farther down and joining it together to the end of the sleeve. So the food goes down this route, and it only has about 3 meters or 300 centimeters where it's mixed with the gastric, with the digestive juices and get for absorption. Whereas normally with the sleeve, the food goes through about anywhere from 5 to 7 meters. So you cut about in half the absorption of the small intestine. So there is a little bit more malabsorption with this bypass. And and there is more issues with vitamin deficiencies, and even a small risk of malnutrition with this surgery. And this surgery I've been using more for patients who their original BMIs is bigger, above 50, and especially for patients with significantly out of control diabetes, because this has been the strongest operation for the resolution of diabetes. Okay, this one still takes me a bit longer, probably about an hour and a half, but incredibly, the patients respond the same way as the other operations. They're almost all ready to go home the next day, and they act just like sleeves. You wouldn't notice, you would never know that we did the second part of the operation to them. Okay. When we compare the weight loss results at 1, 2, and 5 years, here was the band that I'm not even going to talk about anymore, because it really has had poor results for many things, not just weight loss, but for complications. And so we don't offer it anymore. But it was in the literature, it said about 40% extra weight loss for the bands. For the sleeves, we're finding at about a 50, maybe a little bit more than that at 5 years for the sleeves. The bypass is about 60%, and the single anastomosis duodenal switch is close to 80%. So you see, as you get more invasive in the operations, you get more weight loss with these different operations. Okay. Comparing comorbid resolution. So how do they improve medical issues? Same thing with, as you get more invasive, the numbers tend to improve across the board. You get significant resolution of arthritis in patients with sleeve bypass and SADI, in the 40s for all of them, the resolution of arthritis, and an additional improvement of more patients. About 90-95%, almost 99% for the SADIs, resolution of high cholesterol, significant improvement of heartburn, especially with the bypass. The sleeve worries me. It has a lower resolution of heartburn, because some patients can develop heartburn later with the sleeve, and that's one of the things that if you have heartburn, you can get a sleeve. If you have complications from reflux disease, you probably shouldn't get a sleeve, and we would have to talk about that individually with each of you. Resolution of high blood pressure is about the 60-some% across the board, maybe a little higher for the SADI. Resolution of sleep apnea is at about 80%, and resolution of diabetes is anywhere from 70 to 80%, and even a little higher with the duodenal switch. So it really is impressive that we're getting rid of diseases that people thought that they would have never been able to get rid of. You figured once you had diabetes, you had it for life. High blood pressure, you had it for life. But these things are going away after surgery. Complications of the different procedures, I put them together here. If we look at the national literature and our numbers, I'll let you review this, because as you'll see, they're all good. They're all nice and low. The biggest risk for killing a bariatric patient is a blood clot. That's my biggest fear is a blood clot after surgery. And so we're really aggressive in trying to prevent that. And in the literature, it's about 0.4 to 1% blood clots. And right now we're at 0.13%. And then the second biggest killer is a leak, where you join intestine together, it can break down from tension or lack of blood flow, and it's about 1% in the literature, a little lower now, but we're at about 0.2%. Our most common complication is bleeding, and it only happens about 1.3% of the time. We normally don't have to do anything except stop the blood thinners, and we're giving blood thinners because we're scared of blood clots. So normally we just stop the blood thinners. About twice a year, about 1 in 150 patients or so, we'll give a blood transfusion. But only about 1 in 1,000 have we had to return to surgery for bleeding. Bowel obstruction is something that we're seeing rarely, and it's more in the bypasses than in the sleeves, and that's about 0.5%. And then strictures, where things can scar down and be a little tight and cause nausea and vomiting, is about 1.5%. Other things that you can get ulcers and depressions and hernias. And depression, is one that can happen, especially at the beginning, as you're dealing with the big changes in how you use food. And we're changing the way that, we all use our most common drug. So people have to be kind of prepared for that. And for anemias and vitamin and mineral deficiencies, the sleeve, it's almost never seen, but occasionally. And so we supplement all our sleeve patients. And with the bypass, it's seen a little bit more often to see anemia, especially in women who have heavy periods. So we have to really check vitamin levels every year for these operations. Conversion rate means going from laparoscopic to open. I really haven't opened a primary case and I can't even remember how long. And the mortality in the literature is about 0.3%, so about 3 in 1,000. And we looked at our numbers and it was 3 in about 8,000. So I calculated out, unless I did this wrong, I calculated out at 0.0004%. So nice and low. It's not zero, and it wouldn't be realistic if it was zero because it is a major operation. But the incredible part is people talk about the dangers of bariatric surgery. And the funny thing is that the mortality rate of taking out your gallbladder in the United States right now is higher than the mortality rate of getting a gastric bypass. And it's just because bariatric surgery is being done at fewer centers that are specializing in the care, and the outcomes are actually really darn good. So when people talk about how risky this operation is, they really just don't know the data. Okay, latest complications. So, oh, it didn't show up. I'm sorry. So I was trying to show you a report that we get because everything is very transparent right now. And we just got our latest report from last year's complication rates, and we did really well. For our sleeves, our readmission rate was about 2.5%, which is less than expected. Our reoperation rate was 0.3 or 0.4%. And we had one bleed last year in our sleeve. And in our bypass, we did 48 bypasses and had no readmissions, no reoperations, no complications from that surgery. So we had done really well. And I'm sorry, I don't know why it didn't pop up here tonight. Okay, follow-up visits. I said it earlier, we want to see you guys forever. And this is kind of the schedule where we see people at a week, a month, 3, 6, 9, 1 year, 18, and then every year after the second year, we want to see you. And some people we see more often, and especially the nutritionists see patients more often than this. So actually, before I get to this, people ask me how we choose operations. And I kind of go back to this, and I go back to what is your goal for surgery? Is your goal that your arthritis is so bad that you need to get your weight down so that your knees don't hurt as much, and you're scared of a gastric bypass? Well, then a sleeve is a better option for you. If your goal is that you have diabetes and heart disease, and you're scared of the diabetes and you want it to go away, then a bypass or potentially even a SADI is a better option for you. So I don't look at how much weight the patient has to lose as a real indicator for which surgery to choose, except for maybe the SADIs with the higher BMIs. But between the sleeve and the bypass, the weight loss difference is not that much. It's about 10%. So, people tell me all the time, oh, I don't have so much weight to lose, so I want a sleeve. And I think that's a wrong way to look at it, because the weight loss differential is not that much. And this is just an average. So there's a bigger variety within each operation than there is between the two. But I think that if you're looking at it, you look at your comorbid conditions, and so sicker people that have more medical issues should try to resolve those medical issues with the operation that works stronger and better for them. And usually that's the bypass. And I reserve the sleeve more for people who don't have as many medical issues, have to lose the weight to prevent it from coming on, and are worried and don't want to undergo a gastric bypass or have other reasons for it. Let's see what about that. Okay, so I kind of flew through this tonight. But anyway, we can let you know, our office can let you know about your insurance company, and if they cover surgery or if they don't cover surgery. Sometimes, unfortunately, in the state of Florida, many don't cover bariatric surgery. But we can tell you, about the ones that do and don't. And then if they don't, you can ask them about financing options. People hide it, and I don't know why. Transparency, I think, is the new important thing. Our price for a gastric bypass and a sleeve is $16,500. And I say it because I'm very proud of it. It is super cheap. We've had the same price for about 14 years, and I haven't let the hospital change the price. And we're well under a lot of the other people in South Florida and around the country. But I think it's important because it's still a lot of money. But so we do have financing options with an outside company, and the office can help you with that. But you should know what you're getting yourself into. So hiding price, I think, is kind of dumb. But anyway, that's our number, and they can help you with that as well. And if you finish tonight, my biggest goal for people tonight is not to convince everybody to get bariatric surgery, because I know a lot of you can only convince yourself that it's the right time. My goal is to open your minds to the idea that obesity is a medical issue, and that it causes medical problems. And even if you don't feel it that much right now, it will cause more problems down the road. And that staying obese is a problem and causes earlier death in a lot of patients. So even if you don't think you're going to get bariatric surgery, please start looking into other options, and look and work with a physician or a nutritionist to try to lose weight. And one of the interesting things is many insurance companies mandate a 6-month diet history before surgery anyway. So you can come do it with us, or if you don't want to talk to us because you're scared, we're going to pressure you into something, you go do it on your own, but get it documented with your physician or a nutritionist, because I've had too many patients come to one of these seminars, spend 6-8 months doing a diet, lose weight well, but then unfortunately you gain the weight back, come see me a year later, and because they didn't get their diet documented, I had to waste 6 more months of their lives getting them on a diet again, so the insurance company would pay for their surgery. So if you're going to do it, start getting it documented so that it can help you in the future if you need to. And I didn't go into it. The new medicines, I think the new medicines are great. I think they have great outcomes. They're shorter term for right now. There haven't been long-term studies yet. No one knows yet what's going to happen if patients are going to be able to be on these things 5 years, 7 years, 10 years. The hope is they will be able to. They're real expensive now. Hopefully the prices will come down with time. But weight loss has been really good. And I think it's great. I think anything that can help people get down, we sure don't have the capability. And as a country, we don't even have the money to be able to operate on everybody who is a candidate for bariatric surgery. So, but we also can't pay for the obesity problems that we have in this country either. So we need to be working on it from all angles, trying to make it better. And so I'm a big believer in do something about the problem. Don't ignore it. Don't be an ostrich and stick your head in the sand. And if it's with surgery, I'm happy to help you. I think we have the best center in South Florida, maybe even the entire state. And if it's not, I just hope that I've been able to convince you to do something about it, because your life is worth it, and your health is worth it, and your family's worth it to have you around. So definitely do something about it. Okay.
Thank you, Dr. De La Cruz-Muñoz. That was enlightening. And wow, thank you for your transparency and openness like this to talk to people one-on-one. So often we say, our physicians talk down to us, and you really, you got down to the nitty-gritty. You talk about the price and the fact that insurance may or may not cover and so forth. So let's launch into our first questions, because we have so many, and our audience has been putting a lot of in the Q&A chat. So let's start off with this one. I'm 55 years old. I've been diagnosed with smoldering multiple myeloma, which has 20% chance of developing. Am I a candidate for bariatric surgery?
Actually, yeah. So there have been a lot of, in the old days, the answer with cancer was no, but now we've realized we were wrong. And we're doing surgeries with cancer. Sometimes we're even operating with a surgical oncologist at the same time, getting rid of a cancer and doing a bariatric surgery at the same time. So with multiple myeloma specifically, there's data showing that weight loss can reduce the risk of that smoldering multiple myeloma ever developing into an acute attack, an acute myeloma. So yes, not only are you a potential candidate, but I think you would be a great candidate for reducing your own cancer risks.
Yeah, and because you specifically talked about hormonally based cancers driving, with the weight situation. So essentially, it's not just myeloma, but it could be a number of others.
There are 13 different ones, and I always forget the list, but it's breast cancer is huge, the reduction in risk with weight loss. Uterine cancer, weight loss is the number one predictor of recurrence of uterine cancer. So we get a lot of referrals from our gynecologic oncologists after uterine cancer. But you also see it with esophageal cancer, gastric cancer, colon cancer, pancreatic cancer, liver cancer. There's a bunch of different other cancers because obesity, is a hormonal disease, and it's also a chronic inflammatory disease. And so it helps create a cancerogenic environment that increases the risk of cancers and helps them proliferate better. So if we can help with the weight loss, we help decrease that risk. And that's why the risk of cancer deaths in that study was I think it was 29-30%. And in one other study it was down 60% after surgery.
Yeah. Some of the questions coming in, and it's going to dovetail into this next one, are about which is the lower risk of the surgeries, which is the least invasive of the surgeries, et cetera, et cetera.
Yeah.
So here's the question that I'm going to pose to you is, I never thought of surgery until receiving the email about the webinar. So how would I know when it's time for surgical intervention? And why is the surgical option with best outcomes the most dangerous?
Yeah. So I think when you're ready, when you've tried other things, when you feel like you put in effort, no one wants to volunteer to get surgery. And so people will, they try everything before they come see me. And so when you've tried and it hasn't worked, and you finally realize that your health is more important than your pride, then people come get surgery. And in terms of why is it the most dangerous? Well, you know what? It's because it's the most beneficial. And unfortunately, that's the best option that we have right now, the most effective. And like I showed you with the data, it's actually safer than people say. Would you say, if you were doing a news story, you're getting your gallbladder taken out because your gallbladder is no good. How do you feel undergoing this dangerous operation? Well, the data shows that your chance of dying getting your gallbladder out is higher than it is getting your gastric bypass. Wow. But we don't think that way. It's just because we think about obesity differently than we think of other medical diseases. And so our risk tolerance is different. But unfortunately, it is what it is. And until we can develop better other treatment options, surgery really is the one way that has been successful for most patients.
Let's talk about then not having the surgery. What are the other options for weight loss, especially since what you talked about is that in many cases of obesity, it's genetics, not lifestyle, not character weakness, etc. What are other options then?
Yeah, there's a lot of data out there, and Harvard published a study a long time ago saying that their estimate was about 70% of a patient's propensity to obesity was genetic, and not even what they were doing. So, obesity treatment starts with diet and exercise modification. And I'm a big believer that, no one knows what the right diet is. You go on social media and you hear all sorts of stuff, and everybody, it's a guru and everyone's selling you something. But, I'm a big believer, based on what I've seen and heard, of a low carb, relatively healthy diet. I don't go I wouldn't recommend completely keto because it's hard to maintain. And also I'm worried about raising cholesterol levels up high. Some people say it doesn't matter. I don't know. The current thinking is that it does. But so starting with a low carb diet that I think is feasible to do in the long term. Now, the other thing is, I think our food supply is bad. I think it's too processed, and that's the poison that is affecting our genes. So if you just eat less food, you're always going to fail because you're giving your genes the same stimulation to gain weight. And what I always recommend to my patients is go as organic and natural food, whole food as you can. Stay away from anything processed. Stay away with anything that has hormones and other additives. But try to go to meats and vegetables and fruits. And that way you get your genes, after a while, start getting those old signals back. Okay, so that's diet. Exercise is important as well. People think that, all it is you have to get in the gym and work out. Really, the studies have looked at it. You only gain an extra 6 to 8 pounds of weight loss if you exercise versus just doing a diet alone. So it's not a huge difference, but it appears that exercise is really important in the maintenance of weight loss. And we really focus on our patients post-operatively because I think that if you're doing exercise, especially resistance training, it helps maintain a muscle mass, which helps then burn more fat and maintain the weight loss in the longer term. On top of that, then there are medicines. Some of the new GLP-1 analogs are great drugs for diabetes, and they're also great for weight loss. And they've been the hottest thing in the news all over the place. So
the
much,
whole Ozempic thing.
yeah, so much so that you can't even get it because it's there's a shortage. And it's a good, they're good meds and they have good weight loss. I think an average of like 30 pounds in the trial, and I've seen people do more. I've seen people do less, but I've seen others do more. And so, those are drugs. It's funny. Those are the Ozempic is the hormone one of the hormones that's manipulated after bariatric surgery. That GLP-1 spikes real high after surgery. So it's kind of funny that's the drug that seems to work the best right now for weight loss. And doing drugs has always had some problems. One is the cost. And they remain very, very costly. The insurance companies aren't covering them, and so you have to pay out of pocket for it. And secondly, in the older meds has been side effects that people after a while got off of them because it made their blood pressure worse or made them jittery or whatever. And now these ones don't tend to have the same bad side effects as the old ones, but the cost issue is still there. So the question is, are people going to continue paying $1,000 a month for this for how many years before they finally stop doing it? So that the jury's still out on that, but I think as an option is definitely there. The endoscopic stuff I mentioned very briefly in the talk, and I think that's for patients that are just below the bariatric numbers and are considering something. They're just quite not ready mentally for a bariatric procedure, and then the bariatric stuff at the end.
Yeah, let's see if we can get through a bunch of these questions, because a lot of people are asking about diabetes and hypertension, which you just alluded to. Are they eligible candidates for this surgery?
Yeah, the sicker they are, the better patients they are, the better candidates they are for surgery, because we can help get rid of some of those things. We operate on liver transplant patients. I operate on patients that need heart transplants because their hearts are so weak. I operate on people that have had diabetes for 15, 20, 30 years to the point where their kidneys have failed and they've gotten kidney transplants, or they're on dialysis from it. So, and we make significant changes in those patients' lives. So yeah, those are great patients for us to see.
How about a vegetarian? Apparently someone entered a question. Would you need to stop being just solo vegetarian diet before surgery?
You don't, neither before nor after. My nutritionist is not a vegetarian, so it kind of gives you a look like, because then he's got to change his recommendations, but he can do it. And it's just maintaining adequate protein with less volume. Now there are pea proteins and other types of protein powders that you can do that are vegetarian and even vegan. So it can be done. It just requires a change in our guidelines a little bit.
All right, let's jump to this one. With significant weight loss of 150 pounds plus, obviously there are changes to the body, excess skin, stretch marks, etc. Are there additional procedures to correct that?
So there are some people will have enough excess skin that they want to get surgery, and probably in our patients about 20% will get something. The majority won't, just because they don't feel like undergoing another surgery, and they find out that it's not as bad as they thought it was going to be. So many don't end up getting a second surgery, but there are all sorts of, if you follow any plastic surgeon online, you see all the different options, the things they can offer from breasts to tummies to backs to arms to eyelids to necks. You can get redone from top to bottom if you want. I always tell patients there's no plastic surgery police that comes around and says, hey, you need to get surgery. It's up to the patient and what they want to do and how they want to feel.
That's right, because it's a state of mind as well as a physical major change.
And like I said, it's usually not as bad as they think it's going to be, because they've all seen the pictures online of somebody who's lost 200 pounds, 300 pounds, and they're all scared that that's what they're going to look like. And the great majority don't look like that.
Yeah, it's also, I'm sure, dependent on age. So let's get through a few of these really quickly. So from beginning of a consult to surgery, how long would you say?
Every single patient asks me, and my answer is always the same. I have no idea. But the office staff knows. And the reason why is because it depends on the insurance plan. For people that are self-paying, they can normally do it in about 1.5 to 2 months. So that's how long it takes to do the stuff I want you to do. The insurance plan may then tack on an additional 3 to 6 months on top of that. And that's why we need to know your plan specifically.
And that's why you also talked about insurance, and you talked about the fact that the insurance, rather that your procedure costs $16,000 because insurance is very limited in coverage. You have made that point.
Yeah, in the state of Florida, a lot of people don't have insurance coverage for it, and so we do get a lot of patients that self-pay the surgery, but some people do, and it's worth checking to see.
Okay, here's two really good questions that I thought were interesting. This is a parent asking, is my 18-year-old son eligible for this surgery?
Yeah, you know, the American Association of Pediatrics put out guidelines about a month ago, talking about obesity management in kids, and they added for the first time ever bariatric surgery. And the data that I showed you, our 15-year data, was in our adolescent patients. My youngest patient was 12 years old that I operated on, and we have a bunch of them under 18. So so they definitely can get surgery. It changes their lives. I like the fact that, you know, they get it. If they get it before high school, then they get to start high school as a new person, feeling more, you know, self-confident, more normal, not getting picked on as much as the bigger kid. If we do it before they go to college, it's the same thing. They get a brand new start in life with a whole new group of friends. So it definitely can be done with kids. Our study showed that, you know, 93% of them were super happy and glad that they had undergone the surgery at that time, when they did, when I talked to them 15 years later. So actually doing it as a kid is better. The results, the resolution of medical problems and weight loss is actually better than if you wait longer.
Yeah. And I imagine in this case, it has to be a strong family situation where they all come together and the parents really are side by side with the kid. Okay,
Yes.
real quick here. How about fatty liver reversal and thyroid disease reversals?
Okay, so fatty liver definitely gets better after bariatric surgery, and we've seen a lot of it. The inflammation actually can go away. So it has been big, and that's been studied a lot. Thyroid has also been looked at, and the data is kind of inconclusive. Most of the data says there's no significant change in thyroid function. Where I've seen people get off their Synthroid and the thyroid medicine is where I think that the thyroid medicine was used inappropriately by a primary to try to see if they could induce weight loss. And they told them, well, your thyroid's a little low, you're overweight, we'll put you on it. And then after surgery, when they lost weight, the thyroid was still a little low, but the primary said, yeah, we'll take you off. So I don't think it makes a difference in thyroid function.
Okay. And then how about this one? Because I'm assuming that someone who has had morbid obesity for a long time perhaps could be suffering from anxiety and depression. Will the surgery affect that? Can a depressed person qualify for the surgery?
Okay, so you're exactly right. The obese or patients with obesity have higher rates of anxiety and depression than the standard population, and the surgery can definitely affect it and make it worse. So that's why they all get evaluated beforehand, and we need to make sure that they're under treatment, both under, you know, pharmacologic therapy if needed, and counseling as needed as well. People with depression can definitely go through the surgery very well. But we want to make sure that they're stable and getting treatment. And that's the big step for it.
Yeah. I would just ask that you've spoken so candidly from the heart, and we so appreciate that, because like I said at the beginning, I don't think that patients are used to that oftentimes with our physicians. Just give us some closing thoughts on what you see day to day with your patient population and how you see the outcomes and changing lives.
I'm a general surgeon by training. And so before I started doing a lot of bariatric surgery, I did everything. I did a lot of cancer surgery. I did tons of vascular surgery with hernias, everything. And patients are grateful to their surgeons for helping them. Even patients that when you do cancer surgery are very grateful. But the bariatric patients are the most grateful of all, because I think not only do we take care of a problem that they had, but we actually give them a second chance at life. And it's been the most gratifying career for me to help thousands of patients get a second chance at life. And when I see them, you know, I have tons of Facebook friends of my patients online, and years later they're reaching out to me and messaging me, oh, thank you so much. You know, this has happened and that has happened. And it has been so wonderful that that it has been an incredibly gratifying experience, and I wouldn't trade that for anything. So it also has shown me what a big deal bariatrics is. And actually, one more point that you made me think about, I've asked patients who have had complications with me, would they do it again? And I'm talking about patients who over the years have had major complications, needed a couple of other surgeries, been in the hospital for a long time, been real sick, suffered a lot. When they got better and I saw them 4 months later, 6 months later, I would ask every single one of them, would they do it again? And every single one without hesitation said, yeah, I would. And then I would ask them, would you do it again if I promised you had the exact same outcome, same complication, same suffering that you went through? And all of them thought about it, and every single one said, yeah, I would do it again.
And,
So
and do you often see the rebound, sort of the weight gain again, a reversal after the surgeries? Is that common or not?
it depends on the operation. With the bypass, they say it's about 15-20%. With the sleeve, it's probably about 30%, 35%. So it's not uncommon, but luckily the great majority still do incredibly well. Yeah.
Well, we have to wrap things up, and I think we left it on the right message and the right mindset for all the people who joined us tonight. We thank you. You were very active in your participation. And of course, Dr. De La Cruz-Muñoz, the generosity of your time. We cannot thank you enough, really. Thank you so very much.
Well, thank you, Liliana. I appreciate it.
And we're going to put up on the screen so that everyone can know exactly what to do and where to go to learn more about UHealth Bariatrics Specialists. It's uhealthbariatrics.com to make an appointment. And also here's the number, 305-689-1910. By the way, those of you registered for this are going to get a recording of this webinar afterwards in your email, so look for that. And also, please complete the survey at the end of the talk. We want some feedback on your experience and other topics you'd be of interest to you. So good night, doctor. Good night to all of you. Stay well and be safe out there.
Good night. Bye.